Today we'll be discussing about vagus nerve. It is the 10th cranial nerve, also named as pneumogastric nerve and also called as wandering nerve because of its extensive distribution. It forms the cranial part of parasympathetic system, supplies derivatives of foregut, midgut and heart. There are three parts: cervical part in the neck, thoracic part and abdominal part. The cervical part presents two ganglion, superior ganglion otherwise called as jugular ganglion and inferior ganglion otherwise called as nodose ganglion. Superior ganglion or jugular ganglion, small, 4 millimeters in diameter, located in jugular foramen. It consists of pseudo-unipolar nerve cells. So these form the sensory neurons for general somatic pathway. Inferior ganglion or nodose ganglion, 2.5 centimeters long and 5 millimeter in diameter. It also has pseudo-unipolar neurons. So these are the sensory neurons for general visceral and special visceral sensations. Cranial part of the accessory nerve joins with the trunk of vagus nerve below the nodose ganglion. It also communicates with superior cervical sympathetic ganglion and also with the hypoglossal nerve. So you can see here, these are the rootlets of the vagus nerve. So this is the jugular ganglion, this is the nodose ganglion, and you can see this green color. This is the cranial part of the accessory nerve, which is traveling along with the vagus nerve and giving pharyngeal branch and recurrent laryngeal branch and cardiac branches. So from this, it is clear that the pharyngeal branch and recurrent laryngeal nerve are contributed by the cranial part of the accessory nerve. Nuclear components. First one is the nucleus ambiguous. So special visceral efferent, otherwise called branchiomotor, supplies the striated muscles of pharynx and larynx. So few motor fibers also come from cranial root of accessory nerve. So nucleus ambiguous also contains few cardioinhibitor fibers. Dorsal nucleus of vagus nerve, it's a mixed nucleus. General visceral efferent and general visceral afferent. So if we take the first component, the visceromotor fibers, so which supply preganglionic parasympathetic fibers to heart, and to smooth muscles and glands of trachea, bronchi, bronchioles, esophagus, stomach, small intestine, and large intestine up to junction of right 2/3 and left 1/3 of the transverse colon. Postganglionic neurons are in the walls of the target organs. For example, SA node and AV node of heart, Auerbach's plexus and Meissner's plexus of intestines. Viscerosensory fibers from the foreside organs terminate in dorsal nucleus of vagus. Cells of origin are located in nodose ganglion. They carry the organic sensations like nausea, hunger, sensations concerned with swallowing, cardiovascular reflexes, and Herring-Breuer reflex. So this Herring-Breuer reflex will alter the tidal volume, which will be mediated through stress receptors and irritable receptors. Nucleus of tractus solitarius. So special visceral afferent taste from vallecula and piriform fossa via internal laryngeal nerve is carried to this nucleus. So nucleus of spinal tract of trigeminal nerve, general somatic afferent, receives pain, tactile and thermal sensations from external acoustic meatus, tympanic membrane via auricular branch of vagus. So cells of origin located in the superior ganglion of the vagus nerve. You can see here the four nuclear components: nucleus ambiguous, branchiomotor, dorsal nucleus of vagus, mixed nucleus, nucleus of tractus solitarius, special visceral afferent, taste sensation, spinal nucleus of trigeminal nerve. Then course and relations in the head and neck. So starting from its emergence from the brainstem, 10 or more rootlets emerge from posterolateral sulcus of the medulla, unite to form trunk in the jugular foramen, runs in common dural sheath with accessory nerve, but they will be separated by an arachnoid septum, descends vertically in carotid sheath between and behind the internal jugular vein laterally and internal and common carotid arteries medially. So medially there will be arteries, laterally there will be veins. So in the root of the neck, so what is happening? There is a slight difference between right side and left side. So right vagus nerve at the root of the neck lies between internal jugular vein and first part of the right subclavian artery, whereas on the left side it lies between left common carotid artery and first part of the left subclavian artery. We can see in this diagram. See here. So this is the right subclavian artery and the internal jugular vein. So it is lying between these two, but on the left side you can see left common carotid and left subclavian. Then you can see the vagus nerve lying here. So thoracic course of the right vagus passes downwards posteromedial to right brachiocephalic vein and superior vena cava. You can see in this diagram, posteromedial to right brachiocephalic vein and superior vena cava. So this will be the superior vena cava. This will be the right brachiocephalic vein. This will be the left brachiocephalic vein, both joining to form the superior vena cava. Accompanies the right surface of the trachea. You can see this is the right surface of the trachea. So you can see this vagus now accompanying the right surface of the trachea. So above the lung root, vagus is separated from the right lung and pleura by the arch of ajagus vein. So here it is not represented, but usually in this location there will be arch of ajagus vein. So here in this location there will be arch of ajagus vein, which will be terminating into the superior vena cava. Passes behind the lung root and divides into branches and joins with branches from second to fourth thoracic ganglia to form pulmonary plexus. So passes behind lung root, divides into branches and joins with few branches from second to fourth thoracic ganglia to form pulmonary plexus. So below the lung root, the fibers of the right vagus surround esophagus and form posterior part of esophageal plexus, and they enter abdomen through esophageal opening of diaphragm as posterior vagal trunk. So if you see, posterior vagal trunk is formed mainly by the right vagus. So left vagus passes downwards between left common carotid and left subclavian arteries, as we have seen in the earlier diagram, under cover of left brachiocephalic vein. Above the aortic arch, it is crossed superficially by the left phrenic nerve. You can see in this diagram. So above the aortic arch, this is the left vagus which is crossed by the left phrenic nerve. Descends anteriorly and to the left of the arch of aorta. Here it is crossed superficially by the left superior intercostal vein. You can see here. Descends anterior and to the left of the arch of aorta. Here it will be crossed by the left superior intercostal vein. You can see this blue line is the left superior intercostal vein. It passes behind the lung root and breaks up into branches to form left posterior pulmonary plexus. Below the lung root, surrounds the front of esophagus, form anterior part of the esophageal plexus, and enters abdomen through esophageal opening of diaphragm as anterior vagal trunk. So anterior vagal trunk is mainly contributed by the left vagus. Posterior vagal trunk is mainly contributed by the right vagus. So abdominal course, anterior vagal trunk. So there are 1 to 3 bundles. Each divides into hepatic and gastric branches. Hepatic branches pass to the right through lesser omentum to reach porta hepatis. Here they divide into ascending branches supplying liver and biliary apparatus, and descending branches, so which are mainly the pyloric branches supplying pre-pyloric part of the stomach, pyloric sphincter and duodenum. Gastric branches divide into 6 to 10 branches and supply anterosuperior surface of the stomach, except pre-pyloric part because it's already supplied by the hepatic branches. Nerve of Laterjet. So main gastric branch of anterior vagal trunk along lesser curvature of stomach extending up to the angular notch. Posterior vagal trunk formed by right vagus nerve divides into gastric and celiac branches. The main gastric nerve of posterior vagal trunk is also called as nerve of Laterjet, which supplies posterior inferior surface of the stomach. Celiac branches accompany the left gastric artery to join celiac plexus and supplies up to the junction of right 2/3 and left 1/3 of the transverse colon. So branches in the neck, from the superior or jugular ganglion, there will be a meningeal branch which supplies the dura mater of the posterior cranial fossa. So this conveys the sensory and sympathetic fibers from the upper cervical spinal nerves and from superior cervical sympathetic ganglion. So auricular branch of vagus, also called as Alterman's nerve, passes upward and backward through mastoid canaliculi and tympanomastoid fissure. Supplies skin of the cranial surface of auricle. So this is the somatic afferent. Floor and posterior wall of the external acoustic meatus. This is also the somatic afferent and adjoining tympanic membrane. So why it is called Alderman's nerve, I'll explain in the clinical aspects in the last slides. So branches in the neck. From the inferior ganglion, pharyngeal branches. Most fibers come from cranial part of the accessory nerve. Joins with pharyngeal branch of glossopharyngeal nerve and superior cervical ganglion of the sympathetic trunk to form pharyngeal plexus, which supplies muscles of the pharynx and soft palate. So here you can see, so pharyngeal branch of the vagus, which actually having the cranial part of the accessory nerve, and pharyngeal branch of glossopharyngeal nerve, and superior cervical ganglion of the sympathetic trunk. So all these form the pharyngeal plexus, which supply the muscles of the pharynx and soft palate. Sensory fibers of these branches are concerned with swallowing reflex. So from inferior ganglion, you can also see the superior laryngeal nerve, which passes forward medial to internal carotid artery, divides into internal and external laryngeal nerves. Internal laryngeal nerve, it is essentially sensory, pierces thyroid membrane, supplies vallicula, piriform fossa, and laryngeal mucous membrane up to vocal folds, supplies transverse arytenoid muscle. So that's why I said it is essentially sensory. That means a very minor part is supplying the transverse arytenoid muscle. And that too, especially, it is proprioceptive. We cannot justify it as a motor. It is proprioceptive. And then external laryngeal nerve, it is motor, accompanies posteromedial to superior thyroid artery, supplies cricothyroid muscle, and gives a tweak to inferior constrictor muscle. Branches to carotid body, joins with the glossopharyngeal nerve, and supplies carotid sinus, which acts as a vasoreceptor, and carotid body, which acts as a chemoreceptor. Cardiac branches consist of superior and inferior branches, so joins with deep cardiac plexus, except inferior cervical cardiac branch of the left vagus. Please remember this. Except the inferior cervical cardiac branch of the left vagus, remaining all contribute to the formation of deep cardiac plexus. So it's concerned with reflex inhibition of cardiac activity. So inferior cervical cardiac branch forms the superficial cardiac plexus. So branches in the neck. From the trunk, you can see the right recurrent laryngeal nerve. So from this onwards, please try to concentrate about the course and relations of this right and left recurrent laryngeal nerves. So right recurrent laryngeal nerve is originating in the neck. So arises at the root of the neck from right vagus, winds around the first part of the right subclavian artery. So this I will justify with the embryological evidence in the further slides. It runs obliquely upwards behind the common carotid artery and lodges in the right tracheoesophageal groove to supply all intrinsic muscles of the larynx except cricothyroid and mucous membrane of larynx below the vocal folds. So it is supplying all intrinsic muscles except cricothyroid, and it also supplies the mucous membrane of larynx below the vocal folds. You can see here, this is the right recurrent laryngeal nerve hooking below the first part of the subclavian artery, right subclavian artery. See, if we trace it above, it is going in relation to the medial surface of the lateral lobe of the thyroid gland. Then it is passing and reaching the larynx, supplying the intrinsic muscles of larynx. Whereas if you see on the left side, see the left recurrent laryngeal nerve is arising at a lower level, hooking below the arch of aorta. So right side it is hooking below the first part of the right subclavian artery, whereas on the left side, left recurrent laryngeal nerve is hooking below the arch of aorta, and it is passing to the left of the ligamentum arteriosum. So I will explain this with the embryological evidence in further slides. So left recurrent laryngeal nerve arises from left vagus when this is crossing the aortic arch anteriorly and to the left. You can see here. So when the left vagus is crossing anterior and to the left of the aortic arch, the left recurrent laryngeal nerve is arising. The winds around the undersurface of arch of aorta behind and to the left of the ligamentum arteriosum. So ligamentum arterium is the remnant of ductus arteriosus. So passes upward between bifurcation of trachea and the aortic arch, lodges in left tracheoesophageal groove. So in the neck, both right and left recurrent laryngeal nerves have similar course. So branches in thorax, both nerves have variable relation with the loop of the inferior thyroid artery. If you see on the right side, the recurrent laryngeal nerve will pass in front and behind the arterial loop almost in the same proportion, like 50-50 chances. Whereas in the left side, majority of the times, the recurrent laryngeal nerve passes behind the loop of the inferior thyroid artery. So it lies in relation to medial surface of the lateral lobe of thyroid gland, as I've shown in the earlier diagram, passes lateral or medial to the ligament of Berry, or sometimes passes through the ligament of Berry, then passes deep to lower border of the inferior constrictor muscle of pharynx, enters larynx behind articulation between cricoid cartilage and inferior horn of the thyroid cartilage. So you can see here, so passing in relation to medial surface of the lateral lobe of the thyroid gland, and you can see in relation to the ligament of Berry, passing in relation to the inferior constrictor. So then, what are the branches of recurrent laryngeal nerves? If we see, there are cardiac branches, 2 or 3, which forms deep cardiac plexus, communicating branches to inferior cervical ganglion of the sympathetic trunk. So branches to trachea and esophagus. So within these structures, they mainly supply the muscles, glands, and mucous membrane, and a motor twig to inferior constrictor of pharynx. So we are dealing with the branches from recurrent laryngeal nerves, cardiac branches, communicating branch to inferior cervical ganglion, branches to trachea and esophagus, mainly the muscles of the trachea, esophagus, glands, and mucous membrane of them. Then motor twig to inferior constrictor of pharynx. So articular branches to cricothyroid and cricoarynoid joints. Then muscular branches to intrinsic muscles of larynx except cricothyroid. Then sensory branches to mucous membrane of larynx below the vocal folds and receives communication from interlaryngeal nerve. So now embryological evidence explaining the different course of the recurrent laryngeal nerves. So both recurrent laryngeal nerves belong to sixth branchial arch. Fibers are derived from cranial part of accessory nerve, as I've shown in the early diagrams. So on the left side, dorsal part of the sixth aortic arch persists as ductus arteriosus. You can see here. So here, this is the ductus arteriosus. Okay. So whereas if you see on the right side, there is no ductus arteriosus. So dorsal part of the sixth aortic arch persists as ductus arteriosus in fetal life. And the same ductus arteriosus after birth is called as ligamentum arteriosum. So fifth arch disappears completely. Left fourth aortic arch forms part of the arch of aorta. So hence, left recurrent laryngeal nerve hooks below arch of aorta on left side of the ligamentum arteriosum. See? So because of this presence of the ductus arteriosus, which is the remnant of the dorsal part of the sixth aortic arch, so left recurrent laryngeal nerve is hooking below the arch of aorta, which is formed from the left fourth aortic arch. Whereas if you see on the right side, you can see there is no ductus arteriosus, and you can also see right side the fourth aortic arch is forming the proximal part of the right subclavian artery. So on the right side, the recurrent laryngeal nerve is hooking below the first part of the right subclavian artery. So this developmental differences of aortic arches between the right side and left side, which are determining that right recurrent laryngeal nerve is higher in origin and hooking below the first part of the right subclavian artery, whereas left recurrent laryngeal nerve is lower in origin and hooking below the left fourth, that is hooking below the arch of aorta, which is derived from the left fourth aortic arch. So right side dorsal part of the sixth aortic arch disappears, fifth arch also disappears, fourth aortic arch forms proximal part of the right subclavian artery. So right recurrent laryngeal nerve hooks below the first part of the right subclavian artery. You can see here clearly. Now after complete development, the left recurrent laryngeal nerve passing below the arch of aorta and to the left of the ligamentum arteriosum, and here right recurrent laryngeal nerve passing below the first part of the right subclavian artery. So sometimes, rarely, right subclavian artery arises from junction of arch of aorta and descending aorta. So in this condition, so what is happening is disappearance of right fourth aortic arch and persistence of right dorsal aorta below the origin of right seventh intersegmental artery. So due to this, right subclavian artery arises from junction of arch of aorta and descending aorta. In this condition, what happens? Right recurrent laryngeal nerve does not recur actually. Okay. on any structure. So it will directly reach the larynx. So in this condition, we cannot call it as recurrent laryngeal nerve. It will be just right laryngeal nerve because it is not recurring upon any structure. So this slide, just to highlight, you observe only this fourth arch because explaining this complete slide is beyond this lecture. So we'll deal with this slide when we are dealing with the development of aortic arches. So timely, if you see on the left side, fourth aortic arch is giving to the development of arch of aorta. Okay. Then on the right side, proximal portion of the right subclavian artery. So branches in the thorax, pulmonary branches, supplies to bronchial tree, lungs, pulmonary blood vessels. Motor fibers are bronchoconstrictor and secretomotor to bronchial glands. Sensory fibers from lungs are concerned with the Herring-Brewer reflex and cough reflex. So pulmonary arteries acts as baroreceptors, whereas pulmonary veins acts as chemoreceptors. So cardiac branches. So from vagus and recurrent laryngeal nerves joins with deep cardiac plexus. So esophageal branches. So these augment peristalsis and stimulate esophageal glands. So in the abdomen, gastric branches. So these are secretomotor to glands, motor to gastric musculature, and inhibitory to pyloric sphincter. Sensory fibers are concerned with hunger and nausea. Hepatic branches and celiac branches. So secretomotor to glands and augments peristalsis. So supply small gut, large gut up to junction of right 2/3 and left 1/3 of the transverse colon. So in addition, they also supply the kidney, gonads, and pancreas and few other structures. So applied aspects. Auricular branch of vagus is irritated by earwax, especially in children. So it results in coughing and vomiting. So syringing the ear with warm water is advisable. So if it is severe enough, it may precipitate cardiac arrest by reflex action. So you can see the syringing for removal of earwax. So then auricular branch of vagus is also called as Alderman's nerve. I said I'll justify this here. So stimulation of the auricular branch of vagus with cotton soaked in rectified spirit increases appetite by enhancing gastric mobility. So this was practiced by British aldermen. So the name is derived as Alderman's nerve. So just before this, people are going to any kind of dinner and all. So they used to stimulate the auricular branch of vagus with the cotton soaked in rectified spirit so that it increases appetite by enhancing gastric motility. So then recurrent laryngeal nerve injury in thyroidectomy is one of the major complications resulting in paralysis of muscles of larynx. So then this is selective vagotomy, which is a very important surgery in earlier days. So which was performed as treatment of peptic ulcer. So nerves of lateral jet of both anterior and posterior vagal trunks are sectioned. But prepyloric and celiac branches are left undivided to retain the peristalsis and sphincteric action. So next picture I'll show you. You can see here. So this is a truncal vagotomy. It is not the selective vagotomy, it is a truncal vagotomy where you can see first the figure A represents the division of the anterior vagus, and then you can see in this the esophagus is being mobilized. Then here you can find the posterior vagal trunk. So here in this we are dividing the posterior vagal trunk. So this should be actually in addition followed by pyloroplasty. Otherwise it results in stasis. So then you can see here this is a highly selective vagotomy. So wherein the trunks are being preserved, but if you see selective branches along the lesser curvature supplying the cardiac and fundic part of the stomach are being sectioned. Okay, but the fibers which are supplying to the pylorus are preserved. So this is the most preferred surgery. And now even after this there is certain modification like truncal vagotomy with antrectomy where gastric secretion is completely removed. So even after this there are latest advances in this surgeries like selective vagotomy combined with pyloroplasty and few more surgeries are there. Discussing those surgeries and the details and indications and complications of that is beyond the scope of this class. So let us conclude with this. So what we have studied was we studied regarding the introduction to vagus, then nuclear components, especially the nucleus ambiguous, dorsal nucleus of vagus, nucleus of tractus solitarius, and spinal nucleus of trigeminal nerve. Then we studied different parts of the vagus now, like cervical part, thoracic part, and abdominal part. Then we studied the branches, and we also studied the embryological evidence suggesting the different course of recurrent laryngeal nerves on right side and left side. And then we studied few applied aspects. So hope this concludes the in detail the gross anatomy of the vagus. Thank you.